welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Welcome to our podcast exploring the ethical considerations surrounding the distribution and access to gene therapy for sickle cell disease and thalassemia. Today, we have the privilege to have with us Professor Mariane de Montalembert, a renowned expert in pediatric hematology and medical ethics. Professor de Montalembert has an extensive experience in treating blood disorders and has been at the forefront of discussions on the ethical implications of these cutting-edge therapies. Thank you for being with us today.
Thank you for inviting me.
So, we want to talk about sickle cell disease and thalassemia. First, what is the standard of care at the moment for sickle cell disease in Europe?
In Europe, the standard of care is first to have a neonatal screening. Neonatal screening is absolutely mandatory because it allows to start very early the prevention of the complication of sickle cell disease. Basically, the treatment relies on antibiotherapy to prevent pneumococcal diseases. Today, pneumococcal diseases are the first cause for death and in children. And it is very important to be able to prevent those pneumococcal infections. And we can do that with immunization and daily penicillin. And then the second standard of care now is for children with HBSS and S-beta-0 thalassemia to use hydroxyurea very soon. Both these treatments are affordable to patients in Europe. They are not affordable in many countries, for instance, in sub-Saharan Africa. And as well, there is almost rarely a systematic neonatal screening in sub-Saharan Africa. With these measures, the more than 97% of children reach adulthood.
So, if these treatments are not available in sub-Saharan Africa, what is the standard of care there?
I should say that there is almost no standard of care in Africa, given that they cannot afford most of the treatments, and which explains the very high mortality of rate in children in sub-Saharan Africa. Inequity in the access to care is one of the most important ethical problems raised by sickle cell disease.
So there has been a lot of research in new drugs also for sickle cell disease and thalassemia. Which drugs are available at the moment in Europe?
The best example is hydroxyurea because it is really in the standard of care in Europe for HBSS and HBs-beta-0 thalassemic children, which represents the vast majority of the patients. And it is started as early as 9 months of age, and it is not available in most African countries. And also a safe transfusion is a very important difference in Europe, because in Europe we have safe blood, and in Africa very often there is not enough blood and not enough control for safety for infectious and immunological issues. So there is really a very different access to care in Europe and in the United States and in Africa.
So most of these drugs that we are very excited about now in Europe, like luspatercept, I think, and mitapivat, and all of these, and of course gene therapy, because of their price tag, also will never be available widely. So, but I'm surprised about is that you're talking about drugs that are not expensive. Like hydroxyurea is not expensive, at least by European standards. And even that is not available yet in these countries. What are your thoughts on how to ameliorate this situation so that a better treatment can be accessed in these countries?
Hydroxyurea, it is not costly at all for European, the more than for European children. All the institutions give it for free to the patients. But in Africa, even if it is not expensive in our European meaning, it is expensive for African parents. They have to pay for the drug, and they can't. I had a colleague, and he said, I give hydroxyurea every 4 months because it's too expensive to give it every day. So every 4 months, I think that there is a baseline level for the patient, but it means that 3 months over 4, the child is not treated, but it's for cost problems. So in fact, children, they survive, and most of them, they have a good life. The median duration of hospitalization for children in my hospital, it is 1 week per year. It's perhaps too much, but it is 1 week per year. But then they enter into adolescence and adulthood, and they face new and really very heavy complications. But so far, there are very, very few available drugs today, because the drugs you have quoted, for instance, etavopivat, mitapivat, they are in research, and they are not available today. And for instance, crizanlizumab, which entailed a lot of hope, but it is available in United States, but no more in Europe. And voxelotor has been stopped. So in fact, there are not many drugs besides hydroxyurea. And the other point is that patients, they know that cure is possible. And when you propose a drug to a family, she says, I want the cure. How to offer the cure? There are, first option, it is bone marrow transplantation. Bone marrow transplantation cures 95% of children who have an HLA identical sibling. But you need to have an HLA identical sibling. And less than 20% of children everywhere have an HLA identical sibling. So once you have an HLA identical sibling, you have 95% probability of being cured. In Africa, there is no HLA typing, and there is very few possibility to perform a bone marrow transplantation. There are experiments in some countries, and they publish they have performed 5 bone marrow transplants. In France, 5 means nothing. It's very, very few. After, the vast majority, 80% of patients, they do not have an HLA identical sibling. So there is a huge hope represented by gene therapy. The first experience in gene therapy was published 10 years ago. It was one of my patients. He was a boy, 13 years old, from the Caribbean islands, and he was submitted to monthly transfusion, and he was cured. And it was fantastic. He was cured 10 years ago. But after time has passed, there are a lot of experiments with several techniques, either using gene addition, which was a technique used for this patient, but not all the patients given gene addition were cured. Majority of them, but not all of them. And also there is gene editing. These techniques, they may be very efficient, but they are awfully expensive. And we do not have long-term results. For instance, in the gene addition techniques, there were 2 reports of leukemias after, and which led the regulatory agencies to be very careful and to add a lot of follow-up data. And they say, yes, a lot of promises, but we need more time to be sure that there are no side effects. And there is a question of communication, because it's very difficult for patients. They read, this patient has been cured, why not my son? Of course, but the communication needs to be done very honestly. and telling the parents it's not so much a matter of money. It is because, in fact, sickle cell disease by itself is awfully costly when you consider monthly transfusion or when you consider repeated hospitalization. It is very costly. What is really a problem is that the institution and the agencies, they ask for more follow-up. They say there are 2 cases of leukemia. Why? How to be sure that the therapy will be totally well, safe? And they ask for time. And very often the communication for the patients, they do not understand. They say it's a problem of money, no, but not only it's a problem of money. And sometimes also they're not informed. You know, I see patients every week. And some patients say, oh no, doctor, you are asking me immunization against influenza. I don't want, it is risky. I want bone marrow transplant. But they are not informed. Or they say, no, I don't want bone marrow transplant. I want gene therapy. But it is the same chemotherapy, which raises the question of preservation of fertility, because it has to be performed, because these chemotherapy have to be combined with preservation of fertility. And there is a huge problem of communicating to patients what is really the treatment. I was in a meeting called ASCAT 2 months ago, and I made a presentation on gene therapy, and people, they were totally unhappy because they understood that there was a chemotherapy, there was a need for preservation of fertility, and also, finally, when the damages of the disease are too severe, there is no hope to reversion of what has been already damaged. So there is a very, I should say, not narrow, but not very wide window to offer those cures, because after the damages are irreversible. So everyone thinks it's a matter of money. It is a problem, but also there are a lot of problems. You need to have a very advanced, to have a very good a very good hospital yard. I had to make 1 month ago a presentation for Africa. So first you need to have a minimum of settings to be able to perform gene therapy. In Europe, there is another issue. When I decide that one of my children I'm following needs a bone marrow transplant, I say it is a common decision with the bone marrow unit, with the family, and then the decision is taken. And then the child has to wait for around 1 year. Why? Because there is no room, because there are no nurses. Because now the reality in most hematological yards is that there are lack of nurses. So he has to wait to find a room. And if we open and add the question of gene therapy, we are not going to stop bone marrow transplant. So we need to recruit nurses. So it's this whole system which has to be modified so that cure can be a reality. But today, money is not the only question. Of course, 2 million per patient is a question. But all the system has to be organized differently. So inequity between North and South is huge.
Yes.
But it is not only about gene therapy. It is about the need to have blood in the South. It is about the need to have morphine. It is about the need to have free care. Because they pay for blood, they pay for morphine, they pay for antibiotics in the South, and they have no money.
There are problems in Europe because also in Europe resources are limited, but there are also problems of informing patients, of really choosing which is the patient that can get this therapy. But we are ages away of what the problems are in Africa or in...
You're right.
So how do you think there is any way that we can help improve this inequity, or in the treatment of sickle cell disease?
I think that awareness has to be increased in the South countries. Some health authorities consider that sickle cell disease should be considered, for instance, as how HIV was considered. Because for HIV, money came from the North.
Okay.
And the thing that for sickle, it should be the same. The North should give money so that government should not pay for sickle cell disease. This is a political problem. I am not able to answer how to solve this problem, that it should be considered by governments as a priority for a country. And it is not so far. So this is the first problem. And if it was considered as a priority, governments could make standard of care free or affordable, which is not. This is the first step to make, of course, hydroxyurea, but penicillin. People are dying from meningitis in Africa, and you can avoid it. First point. Second point, bone marrow transplant there should be short way to aiming children coming from Africa to have a bone marrow transplant in Europe. It has been done. There are a collaboration, for instance, between, I think, Tanzania and Italy, or some, I think, perhaps also in Nigeria. The first point, that there is no HLA typing in Africa. It's not possible. I receive every week a letter from an African country. My daughter has a severe sickle cell disease. I have 4 other children. They have the same blood group, meaning that they do not know that it is not a problem of blood group, but of HLA typing. So what I need is to have blood samples from the family coming from Africa, and to have a first control in Europe. It's not easy. I think that having a lab performing HLA typing in some countries in Africa should be the first step, and it is feasible, but it has to be paid. Then we can organize short way to perform bone marrow transplant in Europe. Second step, to have really centers performing bone marrow transplant in Africa. But it is a whole organization. They need to have safe blood, to have not sterile, but very clean yards, and all of the organization which is needed. And I do not think that it will be possible to perform gene therapy in countries who are not able to perform a bone marrow transplant. It is a question. But I think that given the severity of neutropenia or all the problems which are the same for all post-chemotherapy protocols, you need to have some expertise in bone marrow transplant before experiencing gene therapy. For me, it is a very, very late future in South country gene therapy, honestly, which is dramatic. But in Europe, we can do better. But because if we are only on a very pragmatical point, I think that 2 million euros, if you can make life of people possible, reduce the burden of the disease, it has to be, I think that perhaps it could be done, but after you have to organize, as I said, all organization of hematological system. And it is a problem of the cost of very, very expensive drugs, and which is globally not only ethical, but political and financial, and it is a whole.
How can an association like EHA help to at least gain awareness or advocate in the places where decisions are made to improve this situation, so to reduce this inequity? Do you think EHA can do something?
I think yes, because in the missions of EHA there is information, and as we are doing now, And information, it is the first step, and it is a very good information. Honestly, I am very happy to be part of EHA and rather proud of doing this job. And I think that EHA is very good in teaching and information. I think that creating documents and podcasts and so on, we are good. I think that we could think about collaborations and generalizing collaboration. I think that also information documents to be targeted not only in specialists but for less specialist colleagues would be very important. Yes, I think that there are a lot of things, and after all these debates about institution and regulatory agencies and access to care, EHA brings together a lot of people from different origins and a lot of different jobs. EHA creates links between national societies. In Europe, not all countries perform bone marrow transplantation for benign diseases. For some countries, it's difficult. So, although these countries are European, so I think that information really can be performed with EHA and by EHA.
So yes, the first step is information at the right level for the right people, I imagine, because you need some kind of information for a patient. There is also information for other healthcare providers, and I guess also information for the people who are taking the decisions to understand the situation of the patients, of the hospitals, so I think there is a lot of work in that sense to improve, to at least move the ball forward, get it rolling.
I agree.
And EHA is trying to help in that. And the other thing is really who is going to put the money, to get a place that can do the transplant in another country. But that seems really far away.
No, we can have common decision, but it is not only medical, it is politics.
Mm-hmm.
And we can be within the discussion.
Mm-hmm. Maybe what hematologists can do at the moment is point the problems, really highlight them, and through EHA is one possibility, but to really highlight what the problems are, what they are facing. Is there anything else you would like to say for the audience?
I think we are opening a very difficult discussion, and we are one piece of the puzzle, but politics are other piece, and I think we have discussed how much it is difficult to, and how much it will take time to go further. But I hope that international and European institutions will help. Yes.
Thank you very much for
Thank you.
for this conversation. It has been really enlightening, and thank you for being with us today.
Thank you for invitation.
Thank you to all of you for listening, and if you like this episode, share it with your friends, and see you for the next episode.